Bismillahirrahmanirrahim. My name is Dr. Zaula, Assistant Professor of Surgery. Today, this is first lecture about anesthesia and pain relief. So we will discuss what is the importance of pain relief in perioperative situations. So we will discuss this topic in detail now. As from your physiology knowledge previously, you can define the pain. Whenever you define the pain, it is as an unpleasant but protective sensory and emotional experience associated with actual or potential tissue damage. Unpleasant, protective, sensory, and emotional experience associated with actual or potential tissue damage, or sometimes patients describe it in terms of such damage. It is called pain. Unpleasant sensory and emotional experience. Okay. We will not go into the detail of pain mechanism, but briefly we will discuss this. That tissue damage caused by injury, disease, or inflammation releases endogenous chemicals called allogenics, analgesic, the opposite of which is analgesic, and pain-producing substances into extracellular fluid that surrounds the nociceptors, that is pain receptors. These substances include hydrogen, potassium, serotonin, histamine, prostaglandins, bradykinin, and especially substance P, and many others. They play a casual role in pain associated with inflammation, trauma, and bone tumor, ischemia, and variety of other pathophysiological conditions. In addition to its direct excitatory action of the membrane nociceptors, these agents may have indirect excitatory action of altering the local microcirculation. The analgesic substance can cause increased capillary permeability and or vasoconstriction or even vasodilatation. So pain perception is a complex phenomena involving sophisticated transmission pathway in the nervous system. But any point of signal transmission, we have the opportunity to control that pain. Today's topic is about this. The first thing we will discuss why pain control is important. The first thing is it is a basic human right that he should be a pain-free person. It decreases sufferings, and especially from surgical point of view, it decreases surgical complications. The other aim of the pain treatment is it likelihood decrease the chronic pain development. It increases the patient satisfaction about the surgery, and most importantly, it speeds recovery, decrease length of stay, decrease cost for both for the patient and for the hospital. It increases productivity and quality of life. So we should treat the pain for these aims. It's a basic human right. It decreases human suffering, decreases complication. We will discuss which complications are there which pain produces. It decreases the likelihood of chronic pain development. It increases patient satisfaction. It speeds the recovery. The aim for today is like in fast track surgery, you should increase the recovery, speed of recovery, decrease the length of hospital stay, so decrease cost for both the hospital and for the patient, and it increase the productivity and quality of life of an individual. What are the adverse effects of poor pain control? In cardiovascular system, especially in prone patient, it can cause if there is perioperative poor control pain, poor control of the pain, they may induce myocardial infarction or dysrhythmia. If the patient is especially after abdominal surgery, there's severe pain, he does not move its lungs, so it causes atelectasis and even pneumonia. And the gastrointestinal tract, there may be ileus or even anastomotic failure. Endocrine system, there is a stress hormone release, which causes again, which disturbs the healing process. And hypercoagulable status, because when there is pain for the patient doesn't move, he doesn't mobilize early, so there is DVT, deep venous thrombosis, and pulmonary embolism. And there is impaired immunological state if the pain is not relieved. So it causes infection, cancer, and even it hinders the wound healing. And of course, psychologically, the patient may, due to pain, may go into anxiety, depression, and fatigue. So these are the adverse effects of poor pain control. Again, there is perception that pain is a transient condition during the perioperative period, but it is not transient. It may go into chronic pain syndromes. So this perception should be removed. Uh, and of course, because of this, there will be a good perioperative. Perioperative means before the surgery, during surgery, and after surgery. There should be a good pain control. So first of all, we will, as we define the pain, now we will discuss that how we will assess the patient of pain. Again, first of all, it comes history, which way we will discuss and what in detail, like onset, provoking, and palliative factors, quality and quantity, radiation, and severity and timing. We can also divide the pain like acute pain, which is immediate, like a signal pain or acute appendicitis pain, chronic pain like chronic backache. And there is another variety, acute and chronic. And pain assessment, you should also you should also ask about allergies and intolerance to many drugs and document these drugs. And there's intolerance of pain and may cause nausea, vomiting, hallucination, and disorientation. In modern era, the pain is assessed by visual analog scales. There are different types of scales in which you can assess the pain. The one thing is like in our Pakistan, there is a chart in which there is no pain, mild verbal pain intensity scale, mild pain, moderate pain, severe pain, very severe pain, and worst possible pain. The easy way is in mild pain, the patient experiencing the pain, but his normal routine is not disturbed. And moderate pain, the normal routine is disturbed, and he seeks some of the need medical attention to relieve his pain. And severe pain, there's a definite disturbance of the whole quality of life, and uh, he may need hospitalization to relieve this pain. There's another scale, visual analog scale. You give the patient a line with one end with no pain and one end with worst possible pain, and ask him to indicate how you will scale this pain and this line. Or if the patient is not that much intelligent, then you should, uh, from numeric pain intensity scale is another assessment scale from 0 to 10 possible pain. Or as FACI scale is another. We will discuss this later. Okay? So as we have discussed that there are many possible side effects of the pain, especially affecting the outcome of the surgery. So it is very much important to treat the pain. Pain can be treated with combination of medicine educational program, physical therapy, social intervention, psychological methods, and complementary therapies. There is misconception about the acute pain management perioperatively, and the people give many reasons for poor analgesia. They say that this pain is brief and that not that much harmful because the surgery is a brief duration of treatment, and so they don't give a good analgesia to the patient. The other reason they give that they say that the pain relief, if you relieve the pain of appendicitis with injection or any other things, it will obscure the diagnosis or even its complications. There is another tendency that the patient pain is underestimated and not recognized that the many variety of the patient perception. Every patient, individual patient has a different perception of the pain, and there is a lack of frequent and regular assessment of the pain and any pain relieving measures, especially in our setup. We don't go very often near the patient to assist his patient on regular basis. Another very important reason for poor analgesia is we see that the patient may be addicted to opioids. So the modern era is the modern concept for pain management is multimodal analgesia, using more than one drug for pain control. Because different drugs have different mechanism and site of action along pain pathway, and there's opportunity for each with a low dose, each with a lower dose is required if it is used alone, then alone, can provide a dative or synergistic effect, provide better analgesia, multimodal analgesia. So how we will how we will manage the pain? You can just consider the pain management pathway, the pain pathway. So the first is at the nerve ending, we can give local anesthetic or anti-inflammatory drugs which act at local sites where the trauma or inflammation or disease is there. Then we can give a nerve block, local anesthetic nerve block. And dorsal root ganglion, we can give local anesthetic opioids alpha 2 agonist at the spinal level. And centrally acting opioids, we can give opioids. The WHO analgesic ladder is another concept in which for the pain you should relieve analgesia by a ladder. First of all, you should give non-opioid. If the pain persists or increasing, you should give mild to moderate or mild to moderate pain for opioids plus adjuvant non-steroidal or other drugs. If again the pain persists or increasing, you should give opioids for moderate to severe pain and plus adjuvant therapy. There is another new concept for analgesia, preemptive analgesia. It is the anti-nociceptive treatment that prevents the establishment of altered processing of afferent input which amplifies postoperative pain. Defined as this analgesia starts before surgery. It prevents the establishment of central sensitization caused by incisional injury like surgery. So it covers the period of surgery and initial post-operative period. Now we will discuss in detail the different types of the drugs which are used and for the pain management during surgery. The first line treatment is There is no contraindication like liver damage or anything. You should give acetaminophen, that is paracetamol. Maximum dose is 4 gram per 24 hour. It is both analgesic and antipyretic. If it is not working, you can also give as a first line other NSAIDs. Any NSAIDs can work. They cause COX-2 and COX-2 inhibitors and COX-1 inhibitors. Different types of NSAIDs have different uh, effect. All are as if all should be administered perioperatively for pain management if no contraindication like GI ulceration or blood disorders, coagulopathy, or renal dysfunction. So, like the first line drug is aspirin salicylate, which is not used very often nowadays. The drug and clinical use nowadays are diclofenac sodium and IM and also that new drug ketorolac, which is very good drug for the perioperative analgesia, and it's have very few side effects. Especially, it avoids the addictive effect of opioids, which was used previously. The drug is not, if the NSAIDs are not working, and later the another drug is are opioids. These are central acting and they act on the opioid receptors, have a very good pain relief, but they are their safety and efficacy can be difficult to assess. And also there are very many side effects like nausea, vomiting, sedation, and respiratory depression, and tolerance and addiction. The prototype of this drug is morphine and hydromorphine, which are not available in Pakistan. We use here only tramal and nalbuphine. Other drugs which is available here is codeine, which is 1/10 of potency of the morphine. It is metabolized to morphine in the body. And there is another drug mepridine, which is also a derivative of morphine. Short-acting forms should be administered and controlled release forms should be administered. Opioids can be given in patient-controlled analgesia. This is another concept that you should give the patient a total control to administer it in analgesia whenever he or she feels the pain. It is called patient-controlled analgesia. It allows the patient to reach their own minimum effective analgesic concentration. It is better analgesia and less side effects. It is administered through a machine in which the patient is given a button. Whenever he feels the pain, he administers a bit of drug, and so he can relieve his or her own pain by himself. There's another drug, gabapentin, which is typically an anti-epileptic drug, but it is good for neuropathic pain. Sometimes there is associated nausea and vomiting with the pain. So, in the pain management, post-operative nausea vomiting should also be controlled. And that is because of the surgery and maybe due to side effect of the drugs. So, for control of nausea and vomiting, you should give ondansetron, which is new drug, dimenhydrinate, like gravinate, metoclopramide in the name of Maxolon. So it decreases the pain medication. If the patient is not experiencing pain, nausea and vomiting, his pain is also relieved. You can also give regional anesthesia like local anesthetic regionally to relieve the pain. It binds the sodium channel and decreases the propagation of action potential along the nerves, like lidocaine and bupivacaine. In regional anesthesia, you can give peripheral nerve blocks, or even you can infuse the inject that local anesthetic at the site of surgery only. These are neuroaxial techniques. Another type of pain management, that is spinal subarachnoid anesthesia or epidural anesthesia. There's another technique for the relief of the pain. Benefit of epidural anesthesia, it is superior to IV patient control anesthesia and open abdominal procedures. It reduces the incidence of paralytic ileus. It blunts the stress response in surgery, improves dynamic pain relief, and it reduces systemic opioid requirement, which has a lot of side effects. The only contraindication to epidural block is if the patient refuses, if there is hypovolemia or infection at the site of the insertion after, um, or there is raised intracranial pressure. With opioids, there are a lot of side effects. Although it's a very good drug for the management of the pain, but there are a lot of side effects. If there is a opioid overdose by the patient, which is and which the patient there's a decreased consciousness, and the patient is somnolent, means he is sleepy. So you should stimulate the patient, monitor the vitals, and monitor the ABC, airway, breathing, and circulation. For opioid reversal, there are drugs like naloxone, which has a dose of 0.5 milligram, 0.04 to 0.08 milligram straight. So acute pain assessment is important perioperatively to decrease the complication, and it is the basic right of the patient that he should be pain-free. And for the pain management, we have different drugs and which act on different levels and different methods to relieve the pain. But the aim is a good pain relief. It causes a good outcome for the patient and it decreases the complication. So the first of all, the accurate pain assessment is important. Then make sure that the patient uh, pre-hospital pain regime should be discussed with the patient already. And the modern theory is that you should multimodal pain management. And also when you discharge the patient, we should also give the patient a discharge pain management. The take home message is perioperative pain assessment and pain management is very much important for good outcome of surgery. So you should assist the pain frequently and also manage the pain whatever the way is. There are safe methods for the management of the pain. And not only drugs are there, also the early mobilization, the verbal communication, and the early management of nausea, vomiting, and early feeding also decreases the pain. And you should also give, whenever the patient give, a multimodal pain management. And whenever he goes to the home, he should go with a good discharge pain management plan. Thank you very much. We will discuss all these things one by one whenever you go to the classes or and the OT in detail. This is just a brief discussion about the pain management perioperatively. Thank you very much and assalamu alaikum.